So, good morning, good afternoon, or good evening, based on where you're joining us from today, and welcome to today's webinar. My name is Laura Ceci Galanos. I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization that provides stroke education to health professionals worldwide. Now, it is with great pleasure that we are hosting this educational activity today to highlight the recently published WSO scientific statement in the International Journal of Stroke on pre-hospital stroke care in low and middle income countries. This will be an interactive session that will provide an overview of the statement, its global relevance, the challenges and opportunities in pre-hospital stroke care. It will also feature insights from our leading experts that are here with us today, and it will be followed by a live audience Q&A. Now, before I go ahead and introduce our chair, a quick look at our housekeeping rules. Very simple today. We welcome, as we said, any questions you might have throughout the webinar, and we kindly ask you to use the Q&A box for those in your Zoom control panel. So don't be shy, ask your questions, and they will be addressed at the end. A reminder also that this webinar is recorded, and the recording link will be sent out to you via email shortly after the webinar. It will also be uploaded on the World Stroke Academy and World Stroke Organization websites. And lastly, we kindly invite you to fill in the survey that will pop up on your screens automatically at the end of the webinar, to share your feedback with us, to let us know the next topics you're interested in, but also to claim your certificate of attendance. This is not a CME accredited webinar, but you can claim your certificate of attendance, of participation. Now, without further ado, I will introduce our chair, Dr. Tunkl, neurologist from the Department of Neurology at the University Hospital of Heidelberg in Germany. Christine's focus is on vascular neurology and critical care. She has extensive experience in stroke units, neurointensive care, and telestroke services. But she's with us today as she's passionate about improving access to quality stroke care in resource-limited regions. So, Chrissi, the floor is all yours.
Thank you, Laura, for the kind introduction and the nice words. So, good morning, good evening, and hello to everyone who's joining from different regions of the world. Welcome to today's webinar on pre-hospital stroke care in low and middle income countries. As Laura already introduced, my name is Christine Tunkl. I'm a neurologist from Heidelberg in Germany, and it is my absolute pleasure to chair this session today on behalf of the World Stroke Organization and the World Stroke Academy. So we all know that time is brain, right? In acute ischemic stroke, the concept of the golden window for thrombolysis is well established. And more recently, we've learned that also in ICH, in intracerebral hemorrhage, too, the earlier we intervene, the better the outcome. But what we sometimes forget is that this time window we always talk about, it does not start at the hospital door. It starts at the moment the stroke happens, and that is usually at home. And from there begins already a journey that far often takes much too long. That journey from symptom onset to the hospital door, that is what we call the pre-hospital phase of stroke care. And this phase involves steps that are definitely not granted. That is recognizing the stroke. That is activating emergency medical services, transporting the patient, and getting the patient to the right destination. And in many settings, this phase lengthens in a way that reduces what our in-hospital treatments then can achieve. And despite all our knowledge, this part is frequently the bottleneck and one of our most persistent challenges, that patients often arrive much too late in hospitals. And these delays, we see it all over the world, but they are sometimes more pronounced in resource-limited settings. So in many low and middle income countries, these populations face low public awareness of stroke signs, and pre-hospital emergency services may be limited or even unavailable. The World Stroke Organization's recent scientific statement on pre-hospital stroke care in LMICs is a major step forward. It summarizes the evidence we have. It identifies the gaps we still face, and it lays out a pragmatic roadmap to reduce those delays and thereby to reduce death and disability. This statement, as Laura has already introduced, is part of a broader series by the World Stroke Organization, and they all address key global challenges in stroke care. Through the World Stroke Academy's webinar series, we are spotlighting these challenges. Last week, we already discussed about stroke care in indigenous populations and on frailty in stroke care, and the upcoming sessions will treat CAA. But let's stay with today. So today we are especially fortunate to have three of the authors of the scientific statement with us, each bringing their own deep expertise and global insights. So please, without any further delay, let me welcome Professor Jackie Bosch, Dr. Ivy Sebastian, and Professor Anthony Roth, who's even joining us from his travels in Tasmania, which is in the middle of the night now. So thank you for being here. Those three will present their key findings of the scientific statement, and they will offer insights into global but still context-specific strategies for improving pre-hospital stroke care. And mainly, they will engage with us in a conversation about how we can act on these recommendations in practice. So I'd like to thank all of you for joining today, and I really hope that we will make it a meaningful and action-oriented discussion. And I'm happy now to introduce our invited speakers. So we have the honor to have Professor Jackie Bosch here. Dr. Bosch is an occupational therapist from Canada, and she has a clinical focus on improving outcomes after stroke. She's a professor at the McMaster School of Rehabilitation Science. She's a scientist at the PHRI and the researcher at the McMaster Institute for Research on Aging and the PHRI chair in global stroke rehabilitation. And her research centers on large multinational clinical trials in cardiovascular disease and diabetes. And Dr. Bosch has led the OSCALE project, and that explored implementing stroke care in low resource settings. This study showed that small, cost-effective interventions could significantly improve stroke outcomes, and that highlights the importance of scaling these efforts. And it also demonstrated the need for community-based stroke care. And we also have here Dr. Ivy Sebastian. She's a neurologist from India and currently serves as an associate professor at the Christian Medical College and Hospital in Ludhiana in India. She was not only a fellow of the first cohort of the WSO Future Leaders Program, but she's also a stroke expert trained from the University of Calgary Stroke Program in Canada. So now she holds leadership positions on the WSO Board of Directors and the Global Consortium of Stroke Rehabilitation. And also she serves on the WSO Implementation Task Force and the WSO Task Force on Pre-Hospital Care. Besides, she has actively worked on India's National Stroke Action Plan and is a key contributor to the WHO collaboration that advances stroke care in the Southeast Asia region. And besides all of this, she is also a high-profile author with many publications in high-impact journals and an editor of Intersect and the Journal of American Heart Association. So we all know Ivy as a passionate advocate for transforming stroke care in low and middle income countries, and it's an honor to have you here as well. And last but not least, greetings to Tasmania. It's a special honor to have you here amidst your holidays, Tony. Tony Rudd was a stroke consultant at Guy's and St. Thomas Hospital in London, UK, and he was the National Clinical Director for Stroke for NHS England until he retired in 2019. So now he's an emeritus professor at the stroke medicine at King's College London, and he was responsible for running the program developing national clinical guidelines for stroke and the National Stroke Audit in the UK for over 20 years. And he's the co-editor-in-chief for Advanced Neurology and the past president of the Coalition of Special Stroke Task Forces, which is working to improve pre-hospital care of stroke patients. And he was given a CVE in the Queen's Birthday Honours in 2013. So we have a distinguished faculty here today. And I would like to hand over to the three of you to talk us through the scientific statement. The floor is yours for the next 30 minutes, and then we have plenty of time to discuss specific aspects with you. So thank you very much. Jackie, up to you.
Thank you, Christine. Thanks for that very wonderful introduction for all of us. And I'm going to ask Ivy to start the slide presentation now. We are presenting on behalf of our working group that put together this presentation. I don't know if you can put it into presenter mode. I don't know if everyone, perfect. Thank you, perfect. You've got the three of us, but we're here representing a much larger group, and we're very pleased and privileged to be doing so. Next slide, please. We thought we'd start the presentation by talking about what we're not going to talk about. We are not talking about mobile stroke unit pre-hospital stroke care. We've gone back to the basics. Pre-hospital stroke care in low and middle income countries, next slide please, has been talked about forever. Pre-hospital stroke care has been talked about for many decades. Clearly, in 2014, the Global Stroke Guidelines and Action Plan put stroke onset and presentation to healthcare services at the top of the cascading activities. However, unfortunately, back one slide, Ivy, if you could, thanks. Although it's been clearly established and known for some time, it isn't always implemented in that manner. Now, next slide, please. So we know about it, but these recommendations are primarily based on westernized resourced health systems. These systems don't exist in many parts of the world, much like Christine mentioned. And yet we know 40% of morbidity and 50% of the deaths in low and middle income countries come from treatable emergencies. Now that's not just all stroke, but that's all treatable emergencies. They just don't have the systems in place. And yet we know stroke in particular depends on rapid pre-hospital response. We've got to get people there quickly, within 6 hours, and treated by trained staff who are aware of appropriate protocols. We know all this, but low resource settings lack stroke literacy among the public. People don't know to get there. Just as Christine mentioned, pre-hospital stroke care either is non-existent or vastly under-resourced, and the structured EMS protocols really don't exist for stroke in these settings, or at least are not applicable in these settings. And finally, training stroke healthcare professionals. It isn't common in these settings that we're speaking of and desperately needed. Next slide, please. So our learning objectives, why we set out to talk about our scientific statement in this webinar, is we thought it'd be a great chance to identify pre-hospital stroke care practices in low and middle income countries. We want to highlight the service gaps. Yes, everyone highlights the service gaps, but also the innovations and what people are doing to try to address these gaps. It's quite remarkable. But we're going to use evidence to talk about what works and what doesn't, and also evidence on which to base policy recommendations. Next slide, please. So what we did, Sir Anthony Rudd put together a writing group. I was lucky to be contacted, and he's focused on the WSO future leaders as part of that writing group, particularly from low and middle income countries. So there was representation right across the board. We sat down as a group, a very large group, together to identify the domains of interest, and here they are. We thought it would be great to organize the information in terms of organization of stroke care, the key things we know should happen. Stroke awareness and action in the community, getting people to hospital faster because they know that they need to get to hospital faster and can get there. Training, healthcare provider training in stroke care, the use of diagnostic tools for pre-hospital stroke detection, and finally, EMS service provisions. Those were the domains we organized the information in. And we had a great debate because, as you all know, low and middle income countries are based on a monetary gross domestic product designation. Not all settings in low and middle income countries are low resource. The corollary exists as well. Not all settings in high income countries are high resource. So we want to make a distinction that low resource settings are those that have limited stroke units, limited revascularization and imaging, and limited trained personnel. We call the paper low and middle income countries because we thought people would understand it. We want you to think about low resource settings. This isn't necessarily only applicable in low and middle income countries. We did a scoping review. We started with the intent for a systematic review, but once we started looking at what evidence was out there, and by evidence we mean evidence that things are happening, we realized we needed to go to the gray literature as well as medical databases, and think about the concept in a broader way than only a traditional systematic review. And finally, we thought it was really important not just to make recommendations, but to give you, the reader, an idea of the priority of those recommendations. Immediate recommendations and evidence backing it. We know these work. We think they should happen immediately, no question. High priority might be lacking evidence or have some evidence, but not enough yet to be in the immediate priority category, but still very important. Important considerations, these are the things we know. You know, we know to be important, but we may not have the evidence to back it up right now. Next slide, please. So let's first talk about how the organization of pre-hospital stroke services. What do we know works? Culturally appropriate public health campaigns. That's been talked about for a long time. There's evidence, and we'll talk about that in a sec, but also knowledge. These are needed and helpful. Training of ambulance crews. Efficient models of ambulance transportation and pre-notification. Efficient is the key. Remember, we said we weren't going to talk about mobile stroke units. We're thinking of a far more, a simpler and efficient method for doing so. Stroke training programs for all levels of healthcare providers. We speak about multidisciplinary team care. Everyone on the team needs to know about stroke. We need rapid evaluation and diagnosis, and protocols are the best way to guide those activities for consistency and training. There needs to be access to basic diagnostic services and triaging for patients who are eligible for thrombolysis when they're being brought to thrombolysis-ready centers. And finally, access to physicians with stroke expertise. And this might not be a popular statement, but it doesn't always have to be stroke specialists, but at least people with stroke expertise. Those are our key organizational aspects of pre-hospital stroke services. And from that, we made the following recommendations. Next slide, please. Thanks. That all states should have a funded strategy to support the development of EMS for patients with stroke. In some cases, this might mean a strategy for developing EMS, and we think that should immediately, the protocol for stroke should be embedded within that system. Health systems should also be staffed by people who receive training. At a national level, there is ability to accredit, provide funding for education, and that could be dependent upon the ability to demonstrate medical training for stroke recognition and treatment. Next slide, please. When we look at the community, stroke action awareness, you might have seen this term evolve over time. It started as stroke awareness, but clear recognition that that isn't enough. You actually have to act as well. We know a few things about when it happens poorest and when it happens best. Those with limited health literacy usually have poor health-seeking behavior, no surprise to anyone. And there's also a strong contribution of cultural and religious beliefs in terms of what one does next when symptoms occur. Faith and traditional healers are often contacted initially. They may be the only people available, or they may be the people that are closest to the people having the stroke. We also know that those who are younger, have a higher income and higher education, have greater stroke awareness. So the corollary, older, lower income, lower educational levels, need to be considered when developing community-based stroke action awareness campaigns. Next slide, please. Here's some examples about what's worked. In high-income countries, and we know this is high income, it's mass media campaigns, the FAST campaigns, a 20% improvement on symptom recognition and 19% improvement on intention to call EMS. I think that's an important consideration. That mass media campaign doesn't have to look the same all over the world. It can be different, but the ideas are pretty consistent. And FAST has been adapted, as you all know. If anyone was at the World Stroke Congress in Barcelona, we got to see FAST heroes in action. As the children who've just been through the FAST education came and showed their skills. We know that's translating to the home environment and has a great effect. In Shanghai, China, the Stroke 120 campaign resulted in people were 8 times more likely to arrive to hospital within 3 hours of the onset of stroke symptoms and 9 times more likely to use an ambulance. That's pretty amazing. Nepal, the Stroke Association did a 6-month mass media campaign. They didn't evaluate outcome, but they did evaluate uptake. And basically, they demonstrated the feasibility. They reached over 250,000 people with that 6-month campaign, just based on download information alone. Again, in Nepal, they're looking at getting community health workers to become involved in stroke education. I haven't shown that any outcomes on that one yet, but it's a concept that they've now started to implement. And finally, World Stroke Day campaigns. I'm sure all of your social media platforms lit up, as did mine, as people all over the world actually take a lot of effort to bring World Stroke Day campaigns locally, nationally, and improve awareness. These things are pretty amazing and done with very little funding involved. Next slide, please. So our recommendations are keep those public education campaigns going. And it doesn't have to be high cost, flashy. It can be basic, but they have to recognize the predictors of stroke literacy. Think about who the audience is and how we can most effectively deliver the message. And it has to be sensitive to language and culture. We say it, it's easy to say, we know it, but it can be hard to implement. We also need local needs-based simple strategies to raise public awareness and encourage the use of pre-hospital EMS and rapidly getting to an emergency department. And they need to be locally needs-based because we have to think about whether there is an emergency department to go to. What should someone do in the case where there might not be someone trained at the emergency department in stroke care? Finally, we said it out loud and we're going to keep saying it, that we have to consider the influence of traditional healers and faith leaders in this space and for these campaigns. They are an important part of the community. People rely on them. We no longer can say that, please come to hospital, bypass the traditional healers. Let's talk to the traditional healers and faith leaders and talk about how to improve rapid access to additional care and treatment that could save their lives and increase function. Those are our recommendations on stroke awareness, and I'm going to hand it over to Ivy to talk about education.
Right. Thank you, Jackie. So yes, so the next domain that we looked at was education, especially at the primary care level. And as we understand that pre-hospital stroke care in LMICs is often provided by primary care providers and traditional healers, as we were just alluding to, in addition to paramedical staff as well in regions where they do exist. But there is a lack of knowledge of stroke. There is limited training and the absence of standard pre-hospital clinical guidelines often leads to treatment delays and poorer outcomes in these regions. Studies from Sri Lanka and Pakistan have shown an astonishing proportion of primary care providers who lack the awareness of simple stroke risk factors or the recognition of stroke and TIA symptoms. And also with regards to proper acute management, including thrombolysis, with many of these primary care providers not referring survivors for further care to an appropriate stroke-ready center. And this suboptimal care contributes substantially to the to stroke and cardiovascular disease-related deaths in LMICs. So we've looked at multiple approaches to train the primary care provider, or other words that have been used for this group of would-be physicians or non-neurologists, non-specialists, and multiple approaches have been used to look at training them and have been successfully implemented across many LMICs. We have examples from Nepal with the 4-tiered approach to train non-neurologists. We have the WSO Enigma app-based approach, which was used to train the non-specialists and physicians across 3 LMICs, actually India, Malaysia, and Armenia. And we have the physician-based model, which was used in India to train physicians in Tezpur in northeast part of the country. And all of them have established the effectiveness of the training the trainer model. And similarly, a hub and spoke approach was also used in East Delhi in India to improve stroke awareness among primary care physicians in the region, resulting in increase in the number of patients who presented to the hospital within the window period. There was an improvement in the door-to-door times as well as in the number of, in the percentage of thrombolysis during that period as well. We can also adapt from successful models in high-income countries such as the French TIA or the British Express clinics, which have kind of established models for urgent assessment of TIA or minor strokes in these regions. Use of standardized stroke assessment tools such as the NIHSs and other simplified approaches such as the triage titrate approach can help to make an accurate diagnosis and reduce diagnostic errors in TIA. We spoke about faith-based healers, and we need to understand that traditional healers play a significant role in healthcare, especially in areas with limited access to formal medical services. And they can often be a first point of access in these regions. There has been a growing interest in integrating traditional or faith-based healers along with modern medicine when appropriate to improve healthcare delivery. And collaborating with traditional healers could possibly enhance pre-hospital stroke care in the underserved settings, but also building these partnerships, we need to understand that it would take a lot of time and sustained effort from both ends. So based on this, the recommendations that we proposed were that those involved in pre-hospital care must receive training on stroke diagnosis and optimal pre-hospital response. The method of training needs to be context specific and should consider the components of previous campaigns that have been effective in low and middle income countries. And this is a recommendation of the immediate priority. Additionally, educational programs for general practitioners and paramedical staff should include TIA as well as stroke training. And traditional and faith healer training should also be considered. This was also considered to be an immediate priority. Next, the domain that we looked at was diagnostic tools for detection. So it has been attributed that the disparity in stroke outcomes between low and middle income countries when compared to high income countries is partly due to differences in access to diagnostic tools, capabilities, and resources. If you look at the number of neuroimaging facilities in low and middle income countries, we have around fewer than one CT scanner per 1 million population compared to approximately 40 in high income countries. And so it is easy to understand that timely brain imaging is often unattainable in many of these regions for suspected stroke patients. In addition, the high costs of getting a scan are some of the other factors which limit the feasibility of these tools in LMICs. And so it becomes imperative that we need to consider some low-cost alternatives, and such as point-of-care testing, biomarkers such as fibrillary acidic protein or GFAP, which is gaining a lot of recognition nowadays, especially for ICH. And then additionally, we have NIRS or near-infrared spectroscopy, and these are non-invasive tools which are being explored to rapidly differentiate ICH non-invasively in remote settings where access to CT scanners may not be available. Here is a point-of-care testing for the GFAP. That I've put on the side, and this is the NIRS tool. This is an indigenous NIRS tool that has been developed in India that we are currently looking at rolling out to kind of differentiate ICH from ischemic stroke in the remote settings. Clinical diagnostic tools in many LMICs where the priority in stroke care is not really to is mainly to recognize stroke and to get patients to the hospital for at least basic quality care, and maybe not always for selecting patients for thrombolysis and thrombectomy. And here we have the importance of simple tools like the Cincinnati Prehospital Stroke Scale, which has been popular worldwide for its ease of use and for its sensitivity, and can be used both by community health workers or even laypersons, and it's especially valuable when medical resources are limited. The questionnaire to verify stroke-free status, developed in Pakistan, is another tool which has shown strong sensitivity and specificity when compared to neurologists. And using such clinical tools can help to identify early stroke in the community and can speed up an emergency response even when advanced diagnostics are not available. And so based on this, we recommend that clinician training and use of tools that are simple to learn and implement should be standard practice. And these tools may need to be adapted for local language and culture. And lower cost technology for stroke recognition may be beneficial in LMICs, including alternatives to MRI and CT for diagnostic stroke, such as biomarkers, smart wearables, and AI. But it requires further development and validation before being implemented. Next, we talk about EMS provision and recommendations. There are significant barriers to the effective implementation of EMS services in LMICs. Broadly, we can classify them into structural and organizational barriers, such as the absence of developed or organized EMS systems or networks. What we usually do have are mostly private ambulance systems with high costs. And then to further complicate the congested traffic infrastructures in LMICs, often compel patients to use private transportation as the only viable option. There are some notable public-private initiatives, such as the GVK EMRI plus the Angels Initiative MOU, which was signed between these two enterprises. This is a first-of-a-kind public-private partnership, which is aimed at improving stroke care in India, promising to train over 9,000 EMR professionals across 14 states. We do need to consider that in remote or less accessible regions with poor traffic infrastructure, telemedicine may be necessary to facilitate timely stroke care, especially when addressing the shortage of skilled personnel in these regions. However, we need to be cognizant of the fact that the effectiveness of telemedicine has not been studied well in LMICs, and it is an uncertain area since most of the studies around this are originating mainly from high-income country settings. If you look at EMS staff training, unfortunately, most LMICs have only a few trained EMS personnel despite clear guideline recommendations for EMS personnel training. In Africa, only around 20% offered training to paramedics, and it's even poorer from a survey in Ghana, where it was only around 9% following local protocols for pre-hospital care. And further, it also becomes essential that when we are considering EMS training, we need to take into account local considerations like the local needs, the culture, and the resources into context. A successful example is from Nepal, where they used a scenario-based training protocol for dispatchers, and this has now been implemented in a large ambulance network. The other easily available tools is the Angels Advanced Stroke Life Support, which is a easily available tool for pre-hospital providers. And lastly, I want to talk about accreditation. So there is evidence supporting the use of accreditation to improve pre-hospital stroke care, and this evidence is growing. But again, here the data is mostly from high-income countries. Rescue provides some support for quality monitoring of EMS service provision and also provides the EMS Angels Awards to these centers which meet criteria. So here we have the WHO Quality Services, a planning guide in 2020. This was a guide which was developed for improving the quality of health services by providing actions for national, district, and facility levels of a health system. And this was mainly intended for anyone involved in planning or supporting quality improvement, from government staff to healthcare workers to private sector stakeholders. There has been a long-standing recognition of the need to work at multiple levels, but what do we do with these recommendations? And so here I'll shift from the global standards outlined by WHO to a practical example from India. We have the India EMS project, which demonstrates how these global principles can be locally adapted and has shown real progress in optimizing emergency stroke services and bridging gaps in care on the ground. So the India EMS project is an implementation research study on developing a high quality, patient-centric integrated model for emergency care system in selected districts of the country. This is an ICMR National Task Force and National Health Research Priority Project. And here you can see these are the districts which have been selected for the program. And Dr. Jayaraj Pandian, the current president of WSO, is the principal investigator for this study. And this project, it caters to 9 common conditions in the country, from trauma, burns, STEMI, respiratory illness, and maternal and child health services, but also includes stroke, as you can see. And the aim of the project is to develop a scalable model of high quality, patient-centric, integrated emergency care system with a goal to achieve at least 80% population coverage in the selected districts of India. So this is an overview of the study, and this details the different phases of the study. With the formative research phase consists of mapping the ground level scenario with both health facility and pre-hospital care assessments, engaging stakeholders, and looking at the competency assessments of care providers and first responders. Going on to develop the provisional model, which mainly looks at enhancing first aid at community level, strengthening pre-hospital care level, and looking at interventional strategies at the facility level, in addition to development of AI-based systems as well. And lastly, implementation and optimization of this provision model, and then scaling up the final model in the entire district. So if you look at the EMS ambulance standards from WHO for basic life support ambulance, the recommended ratio is 1 per 100,000 population. Currently in low and middle income countries, this is around and one per 50,000 population. And from the National Health Mission, the ambulance, the advanced life support ambulance should also be 1 per 500,000 population. Ludhiana district, which is a relatively small district in Punjab, but is Punjab's largest district by population. The census of the population was 34,98,739. And if you look at the ratio, we have around 40 BLS ambulances and 1 ALS ambulance. And this currently is running on a public-private partnership mode with the government of Punjab and Zen Plus. So as part of this India EMS project, we looked at the formative research, a community survey was done, and you can see the number of facilities that were assessed, 1 district level hospital, 4 SDHs, community centers, primary health centers, and 56 ambulances were assessed. 68 FTG interviews were conducted, and live interviews and observations, as well as a population coverage of around 26,941. And here you can see that the first action taken was to visit the allopathic facilities. 41% of the allopathic facilities have been covered. 67% of that is from private hospitals, and the rest is from either private clinics or government hospitals or medical colleges. And as you can see, the ambulance utilization from government ambulance is only around 7%, and private ambulance is 1%. And the key insights that we understood from this first survey, here you have the 108 ambulance, which is the government ambulance that is provided in Punjab in the Ludhiana district. So the coverage is adequate. We have 27 ambulances across the entire area. The 41.1% services provided around a 150-kilometer range, and around 38% services around a 50-kilometer radius, of which 96% ambulances are basic life support ambulances. And you can see that emergency supplies, drugs like clopidogrel, oxytocin, activated charcoal, 25% dextrose were not available in these ambulances. IV cannulation is not allowed in these ambulances at present. And generally, this is the human resource. If you look at it, it's manned by 1 EMT professional, 1 driver, and they're generally undertrained without any refresher trainings. And with regards to data management, only patient logbooks are being maintained. So as part of this was the first survey that we had at what the ground level availability of services we have in the city. And as part of this program, we've had initial implementation at the pre-hospital level. We've taken 57 of the 173 ambulance personnel, that is 33% of these professionals have been trained now. They've been trained in both BLS and ALS services. And so that's how we are beginning with this program in the city, and this is being expanded across multiple districts in the country as well. And now I hand it back over to Jackie.
Thank you, Ivy. Ivy's shown a great example of a vast national-based campaign reorganizing ambulance services. And we wanted, which is fantastic, everyone should be thinking at that scale. But it came from identifying the need. And that's where we thought it might be a good point to talk about fast. We all know about fast. Is it a slow story of fast or a fast story of fast? You can decide. But here's how it happened. In 1995, the TPA results were published. In 94, they came out, and there's an article by Snow from 2013. It actually describes Gary Ford saying, it'll never happen in Newcastle upon time. We can never make it happen in time. And that was the beginning of the need for the solution. And we give that to you because you know many of the problems happening in your areas. If you're from low resource settings, you know the problem. You know what has to happen. It's the in-between that's the difficult part. So what happened in 97 is I started talking about, okay, what if we set up a rapid ambulance protocol, something where we can get paramedics to recognize stroke faster and get them to the hospital faster. So the story goes, there's a lot of opposition to it. It required constant problem solving, and all they wanted to do was teach out the paramedics how to better recognize stroke faster. So FAST was developed in 98. They wanted to then not only implement FAST in the paramedic system, but also direct the ambulances to hospitals where there is a stroke unit, where there is stroke care. The hard part here was there was no emergency department. So again, lots of opposition and people had to work things through. I think that relates to one of the questions posted in the Q&A. The paramedics received minimal FAST training and it worked. It wasn't a new degree that was added onto their training. They did it quite quickly, read a manual, and off it went. It worked. And then they got this patients to the they got the patient to the stroke hospital faster. That was great, but they still had to go to ERs where there was no stroke specific training, and that's when Rosier was developed. So from 95 to 2000, we call it slow. I think that's pretty fast. 5 years, but constantly working away at a solution, recognizing it's not going to go in one fell swoop. And I'm sure there were a lot of doors closed before the final ones opened to make this happen. Next slide, please. Forward, Ivy. Perfect. So what we're going to leave you with is a few research and policy priorities. You're probably saying that's what all academics do, but these ones we think really are what's needed. Better epidemiological evidence. It's what we put at the end of every paper, of every study. We need more evidence. But in low and middle income countries, in low resource settings, we do not have the evidence about what's happening. And many of you, I bet on this call today, know that from a North American westernized response when you say, it just really doesn't exist where we are. We need more data. We need to identify effective ways to increase stroke action awareness. People are working on it. There's FAST. There's a lot of FASTs out there. FAST is changing. And that's a great indication of the recognized need. But it doesn't mean we have to stop there. We need low-cost alternatives to paramedic staff. Rapid response teams might be one of the solutions. There was a question about telemedicine. Absolutely. Telemedicine and mobile apps and AI have to be considered in this context to diagnose faster, get people to hospital faster. These would be as valuable in low and middle income countries as they would be in high income countries. Next slide, please. Thanks, Abby. And protocols. Everyone said, we have protocols. I've seen protocols. I've been to many settings in low resource settings where there are protocols and they're stuck on a wall. I don't think they're actually used because I don't think people think they're applicable in those areas. They need to be contextually relevant. Maybe the WSO, the WSA could be the repository for such protocols so that people aren't always reinventing the wheel, because I'm sure there are some places where people would have a more similar systems approach. that could be useful. It also might be a task of the WSO Coalition of Special Task Forces. I did that partly for Tony, but also because I thought, hey, that actually could be a great effort and activity. We've got to get better low-cost imaging technology, everything. That's the only way it's going to be applicable in low resource settings. And basically, we're taking it back to the top of that whole WHO ladder, we'll say, that Ivy showed. We need national pre-hospital stroke policy. People need to say this is an important issue. It is not as prevalent as an infectious disease, but it is as catastrophic to those who have it and the family members who are left to care for them. So that one's no longer a maybe. That one has to happen. Next slide, please. We're going to leave you with these few simple messages, and Tony gets the last word. There are many gaps. No one is surprised by hearing that in low and middle income countries and low resource settings, there are gaps, but there are also efforts being made, and they're being done because people recognize what the need is, recognize where we have to be, and are just working a way to find unique and innovative solutions. We just need to talk about them more. We know that systems won't spontaneously address this issue. We no longer can just make the call to say that governments need to. We need to help governments make that actually happen at all levels. At the hospital level, you can start whatever you think your fast equivalent is, and it can grow to a national and internationally recognized system, much like what's happening in India as well. It all just happens one small solution at a time. Tony, the final word.
Thank you very much indeed, Jackie, Christine, and Ivy. I haven't really got very much to add to what's been said, but I would say that the potential benefits of trying to address some of the really simple problems, which all of you probably on this call think are terribly obvious, simple, small steps within low and middle income countries with huge populations and huge risk of stroke are going to give huge rewards. And if you compare the number of lives that could be saved, the number of patients who could end up with less disability than otherwise, with what the investment we make for very high-tech interventions, such as thrombectomy in high-income countries, the numbers are grossly imbalanced. We'd spend a huge amount of money in our high-income countries for relatively small gains, very important for the individuals that get it, and we spend very little in the low-income countries. So it's easy to sit back and say these are obvious things to do, but it's also understandable that when you start addressing how we tackle these issues, that you throw up your hands in horror and say, it's just too big, it's too difficult. But I think that the examples that Jackie and Ivy have given of small, relatively small interventions actually show that you can make a difference with relatively little cost. The only other point I would make is that I think it's really important that we involve the politicians and the healthcare planners in and get them to understand what the potential benefits would be for fairly small investments. Because without them on our side, the chances of making major change is probably fairly small. So thank you for the talks from Jackie and Ivy. Happy to hear the questions.
Thank you, Jackie. Thank you, Ivy, and Tony for this outstanding and so important work, both the presentation but also the scientific statement itself. So that was clearly a substantial amount of work, and we are very grateful for the way you brought all this wide range of knowledge and evidence together in such a clear manner, covering all the different aspects of pre-hospital care. And also congratulations to Ivy and her team from Ljubljana for their important EMS project. All your examples were very inspiring. Also to hear the story of FAST, again, a tool that we use. It was very interesting to hear about its origins. And definitely all your recommendations will be very helpful as we move forward. So thank you for all the work and thoughts you've put into this work. We now have the unique chance to discuss all further aspects and future perspectives with the authors. So don't miss this opportunity and post your questions or share your ideas or your experience in the Q&A box. And we already have some questions here. So I hope the speakers are ready to engage in the discussion. Let's start with the first question by Ayush Agarwal from Delhi, from India. So the topic telestroke was mentioned briefly before, but I think it's of highest interest to the audience. So maybe we can elaborate a bit more on this. So what do you think? What is exactly the role that telestroke care has in the pre-hospital phase? And also another question from Ayush is, does a mapping of stroke-ready centers in the region can have a beneficial effect, and how could this possibly be done? Because not all hospitals in most of the regions have the capabilities to treat stroke patients.
Ivy, do you want to start with this one, given I'm sure there's been a lot of thought to the second part of that question and the first part in preparing for the effort?
Yeah, sure. Thank you. Thanks, Ayush, for that question. Of course, telestroke definitely can help with pre-hospital stroke care by enabling a remote neurologist input from the time of the first medical contact. We already have examples, as I'm sure you are very well aware of, with the hub and spoke networks that map and link stroke-ready centers across a region. Even from India, we have these examples. One of the examples is from Himachal Pradesh itself, which Ayush, I know Ayush, so I know he's aware. It's a remote kind of a hilly region, geographical terrain in India where you don't have many stroke-ready centers, and they started a hub and spoke kind of a telestroke network here by using simple WhatsApp communications, and this was developed in India. And they were able to start thrombolizing patients across, I think, if I'm not wrong, 27 centers, and it was a successful example. And we have many similar examples from Nepal as well. Christine knows, Ayush knows of those examples as well. And so, yes, definitely, when structured well, this is definitely a modality that can shorten the onset to treatment time and can increase EVT access, EVT access where possible, and strengthen the quality of care at spoke hospitals. Another similar example I would like to give from my own region is the Punjab stroke project. This is again a hub and spoke kind of a setup, and this is the first of its kind public-private partnership between the government of Punjab, Medtronic, and a private hospital, which is CMC Ludhiana. So we serve as the spoke hospital. We serve as the hub hospital, and we across 4 spoke hospitals in Punjab, through an AI platform, which is the Cure AI platform. So any of the patients coming to any of the district hospitals, which are government hospitals across Punjab, they just get a CT scan done, and then we have a teleconference with the non-neurologist at any of these settings, and we are able to provide expertise for thrombolysis, and based on a video consultation along with discussion with the non-neurologist there at those settings, when required, we are able to bring those patients over to CMC at our center for a CT angio and an EVT when required. And this has been a successful model, and we're now expanding it to 10 spoke hospitals across Punjab. So yes, definitely telestroke. I hope that answers your question, Ayush.
Thank you very much for this comprehensive response and highlighting other examples, Ivy. Yes, and the WSO also knows about the importance of telestroke care. So we're happy that the WSO Telestroke Committee was recently founded, and we're going to put a stronger emphasis on how to best apply telestroke care given the different resources in different regions. And there's another question on telestroke care, so that really highlights how important this is going to be in future. Pratwal from Nepal addressed a bit more the post-stroke phase. we are talking about pre-hospital, but maybe Jackie, we have the chance to have you here as a rehab expert. So maybe you can just briefly answer the question, what do you think is the role of telemedicine addressing post-stroke disabilities?
Thanks, Christine. And it's a great question. I thought there was a plant in the audience when I saw it. I'm like, oh, that's kind of where I know more about. Telemedicine is great in rehabilitation, but you have to have the rehabilitation professionals. Human health resources just aren't available in many settings. Physios, more than OTs. So what we need to do is think of creative ways in which to get this information to people. I think it can work. We've been trying to develop different models, actually, of delivery. Could community health workers provide rehabilitation? Very basic aspects, how to transfer, very simple things. That could possibly be a hub and spoke from certain areas. But what's interesting is with the dearth of rehabilitation professionals, it isn't quite the same as, and I know we don't have a ton of neurologists in any of these areas either, but that is actually one of our limitations. So we have to think about how. I think it could. We just need to get the expertise to the people in a way that makes sense within the context. More work to be done, and I'm so excited to hear about the WSO Telemedicine Council, because I'm sure you're looking at that one as well, post-stroke.
Thank you very much. Before we go into the next question from the audience, I would continue on the topic of technology. So you briefly mentioned that AI can play a role in pre-hospital care, and I think we can't have a webinar nowadays without talking about AI, right? So could I ask you, what do you think, where exactly could AI be used in the pre-hospital phase of care? What specific areas do you envision?
Tony, do you want to try that one first?
Yeah, go to the oldest guy with the least computer sort of knowledge. That's great. I mean, I think one example might be, for example, um, using AI to pick up the signs of facial weakness, for example, or speech abnormalities. So someone, a relative or someone at the roadside can hold a mobile phone up to a patient and get an almost instant response potentially. It needs testing, it needs developing. I'm not saying that it's there and ready to use, but you can imagine situations whereby that sort of model of care could actually speed up the diagnosis. And then, of course, getting the patient to the right hospital, giving the information to the taxi driver or whoever it is that's actually doing the transport if there's no ambulance about how to go and where to go. And so I think there are a number of areas where AI might potentially be useful. But we need the research. We need the people listening to this webinar to go away enthused and think, this is a huge area where I could really make an impact.
Tony, thank you. That was a very nice call to action for all of us, right? So we also should not forget to focus our research on AI-related topics. We have more questions from the audience. Parameshwar asked, that comes to you, Jackie, because you elaborated on FAST and the clinical diagnostic tools. So for the early triage, what standardized clinical or reporting frameworks does the WSO recommend to ensure responsible validation? Is there any preferred diagnostic tool?
Wow. I don't know if I can make a WSO recommendation, but we talked about a lot of the tools that are actually available and being used. You know, standardized reporting frameworks. This is all for the early triage FAST, right? Think about all of the different variations on FAST. It's actually pretty accurate. What Tony's talking about takes it to the next domain, I think, and is the reason why people keep trying to revise FAST. It's good, but it's specific, but it's not always that sensitive, particularly I think when symptoms aren't quite overt. So I think we need to do the combination going forward of the tools that exist. You might need to modify them a bit, take a look at all the variations of FAST that are out there. But Fast Heroes actually is the best, I think, education campaign. It's not a triage tool, but the kids seem to know what they're talking about. So if we can get the whole world saying those words, maybe we don't even need to worry about triage. It'll happen automatically.
Could I just add that whichever tool we use, it's really important, particularly in the low and middle income countries, that we keep it simple. It's got to be something which can be taught very quickly, applied very quickly, and in a way that's not then going to be forgotten. And one of the problems with the more sensitive tools that's going to pick up more posterior circulation strokes and so on is that they get so complicated that they end up not being used or not being used properly.
Thank you. Thank you for your responses. I hope that answered your question, Parameshwar. And I would go to the next question. So Dr. Raziel Acosta is joining from Ecuador and works in a region with limited pre-hospital stroke infrastructure. And they're currently exploring ways to improve the early stroke pathway. So, in this region, they are exploring the development of an updated pre-hospital stroke care strategy. And now the question gets very precise and concrete. So, what is your recommendation? What are the core recommendations or essential first steps for designing and implementing an evidence-based protocol that can strengthen early recognition, triage, and time to treatment in resource-limited areas? So, what do you recommend? It's like a summary of your previous recommendations, but where to start? Thank you for this great question, Dr. Raziel.
Shall I kick off? I mean, it
Thank
really
you.
is a little bit like the story of the millipede being asked by somebody, which leg do you move first? And the millipede sits down and thinks and never walks again. My message is that just start with one of those legs. It probably doesn't matter which one. Certainly read the paper because it is a comprehensive, fairly comprehensive review of what we know. Take advice from other places where they've already started the process. So don't reinvent the wheel, but do what is give you the quick deliverables at the beginning. Do what seems easy before you move on to some more difficult things.
Thank you. Jackie or Ivy, do you want to add something?
Yeah, I think Tony, that was very aptly put. I love this millipede story, but yes, definitely the first point would be to start off with whatever you have, but probably understand realistically as to where you stand and what is realistically deliverable in your region. I would say in your area, like map what are the regions or which are the facilities which can actually provide a CT, a rapid CT scan or a 24/7 CT scan, which are the centers which can provide IV thrombolysis and endovascular thrombectomy if available, or neurosurgery, and have an estimate of the true travel times by day or by night. And from there, possibly you could start working on, a kind of a model. If you're working in a hub kind of a place where you can provide these services, and then map out which could be your initial spoke centers. And then start off from there. And of course, another very important step to starting off an acute care pathway would be community and EMS recognition. So simple stroke awareness recognition tools, advocating for FAST or one of the different models of FAST, which the community can pick up, which is kind of context specific to your region, and pair this with a clear message about calling EMS and then start off from there.
Great, thanks. I hope this answered your question. So we learned from the experience of the experienced speakers that there's no one size fits it all, but we really need to do a needs assessment first. And I think that was shown in a brilliant way by you, Ivy, when it comes to the EMS project in India, right? You did a very comprehensive needs assessment first to address the specific problems in your region. Another question from Ecuador. So, talking about money, what are the key elements that help to persuade the regional health authorities to support the development of modern pre-hospital stroke pathway? What is your experience? How did you address the health authorities, or what examples have you encountered from other areas of the world?
Thank you for the question. I think the issue with stroke is it has to be thought of as important. Everyone here obviously does think it important, but on a global scale, if you were the global or the regional health authority, what would you put your money on? So you need the data to actually show the detriment to the people in the region that stroke is causing. And the unique part I think about stroke is unlike any other, or to an extent unlike any other, you all can argue with me, disease, state, the effect on families, the catastrophic expenditure costs for the families is unique. And I don't think people really understand that in places where there are no other ways to support, it is a family caring or not for a stroke survivor. That's it. There's the only option. So I think once we start to understand the implications of stroke to the person and the family, the incidence and prevalence of stroke in that community takes on a different meaning. But to do that, I think you actually have to involve people who have had stroke. And one of the most, unfortunately, the most effective ways is people in the regional health authority when their family members have stroke. Suddenly that becomes a larger issue. Taking the opportunity to talk about stroke whenever is possible, but the data, you need the data.
Thank you, Jackie. I hope this question was answered. But I would have another question on this. I hope I have another minute for this. So you mentioned that data is very important, both for convincing health authorities, but also to get an accreditation or certification of EMS in future. So is there a set of key performance indicators for pre-hospital care? So if we talk about the in-hospital phase, we know that we have things like thrombolysis rate, door-to-needle time, thrombectomy rate, and so on. But is there a similar set for the pre-hospital phase as well?
As far as I know, there is not a well-recognized, standardized set of measures. There are places around the world that are beginning to measure the quality of pre-hospital care. Well, certainly in sort of high-income countries. The UK, for example, has been running an audit of pre-hospital care for a few years now. And I mean, I think that common sense, you could sit down and produce, you know, 5 or 10 measures that would give you some indication of the effectiveness of your services. You know, so the time from call to arrival in the hospital, for example, whether they get to the correct hospital, whether patients are arriving without having called an EMS service at all because it's not available. Those sort of measures one could come up with quite quickly, but they would then need to be tested. And the important thing is to not set measures that you can't, standards that you can't measure. So keeping them simple again and collectible data is the important thing.
Thank you very much. And that leads me to the last question of today. So the WSO has really highlighted the importance of pre-hospital stroke care now with a scientific statement. Is there any planned upcoming initiative on how to proceed, or maybe also on how to produce a set of measures or how to further enhance pre-hospital stroke care?
Everyone's looking at everyone else, so you know the answer. No, but there needs to be. We
Okay,
need the
so
protocols, right? This is something that the WSO, I think, would like to be interested in doing. It's hard to tell the WSO what to do, but since they requested this scientific statement, I think there's interest. We just have to get the people behind it. And the hardest part, I know, in asking for people's time is when you don't have it, how do you give anything more? And those from low and middle income countries are even working harder. So it's asking more from people who have less again, but I think only with the input of people who are actually living the situation is this going to be an effective approach. So those protocols, etc., start writing to your WSO campaign manager, and I'm sure, just like the scientific statement, there might be a interest to move it forward.
Great, thank you very much. I think that was nice final words from Jackie. We all know what we have to do now. And there are no further questions from the audience. So thank you all very much. I think that was a very engaging discussion today. And I'm sure we are all leaving this webinar with concrete ideas on how we can strengthen pre-hospital stroke care in our own settings, or how we can collaborate further in future. So thanks to all of you for joining today. And a special thanks to the speakers for sharing their insights from different regions of the world and from different time zones, even in the middle of the night in Tasmania, and for sharing your thoughtful reflections with us. So we really look forward to the next webinar in this series, which will be on December 4th, on a completely different but equally important topic. It's about the diagnosis and management of cerebral amyloid angiopathy. And now thank you all for being here, and wish you all a very good day, afternoon, good evening, or even good night. Thank you and goodbye.
Bye.